Well, this is exciting because the actual person who knows the most about genetics in our company is the one cited on the talk, Dr. Joanne Armstrong. But Mike knows almost as much as Joanne, and I know that Jan Berger knows a lot. I know a little, and so that should make it an exciting session. So here we go. So one thing I was thinking of, and I want Jan and Mike's opinion, because this actually is contentious despite the ideal presentation of, there's a feedback here. Could have like a air guitar thing. The ideal situation is all patients will have the best genetic counseling they can get. In person, telephonic, before anything's done, before there's any misunderstanding. So in the companion diagnostic world, I want to ask Jan and then Mike, who should be doing the counseling for this in order to get it done in today's real world? Jan, I'll start with you.
Well, and I'm going to be speaking on behalf of employers today because they are the ones who often are deciding what the health plans are going to cover and not cover. And I do a lot of work with employer groups and employer coalitions. So just to give you a basis of where I'm coming from on a lot of this. So you ask who should be doing it. The first question is, and I think Karen brought it up, we don't have enough counselors. And the training on counselors is tough. Some of the docs are well-informed, many of the docs are not. So who should be doing it is a really tough question, and there isn't a good answer because we don't have enough. It does take us back to the days of, I'll show my age, in the 80s, and HIV counseling. And if you are going to be holding up an appropriate test because you don't have the counselors that are available and appropriate counselors, it creates a real big problem. And I can tell you, as employers and employer coalitions are looking at this, we don't have a good answer yet.
What do you think, Mike?
So there's any number of problems with the data as we currently have it. Among them are a good understanding of who's ordering the test, a good understanding of what the patient experiences as a consequence of the test, health resource consumption as a consequence of the test. All those are black boxes. We actually don't know hardly any of that stuff. And the situation is further complicated by the fact that what used to be the rules is about to change, like dramatically. And it's going to change for two reasons. One is that next-gen sequencing is going to change the rules completely. So we went from an argument about whether you could have a patent on the BRCA test to a world in which there'll be a platform for under $1,000 where you can test for every single known hereditary susceptibility to everything. And I'm not just talking about cancer, I'm talking about everything. And there are people who feel very, very strongly that should be done to everybody, Now there's obviously some challenges with that. Among them, not everybody wants to know. And then further, there are issues regarding, and this was touched on by Karen, whether or not the people who are doing the tests are actually doing it right. And then the fact that our knowledge set, our database regarding polymorphisms versus mutations is totally incomplete. So we can freak people out. So the rules in the past may not be applicable to where we're going in the future. And I think we're going to have to take a step back and really think. Because as I've said to Iris, we talk about somatic mutation analysis and directing therapy based on that. So the population that is geared for are people with cancer. The population for whom this is geared is America. Just think about that for a second.
That is a little bit scary. So, I mean, I think and Karen touched on it, but I think, the ground rules of this are for testing, and we're here talking about companion diagnostic testing, but for all of this, you've got to have analytic validity. So if, Bob's genomic testing shop down the road opens up because the Myriad, court case went through, how many of these rogue labs are you going to really trust? So you've got quality control problems. So we've got analytic validity, and then clinical validity and clinical utility. And Karen talked a lot about clinical utility, and I think that as the tests become not just for people with cancer, but for the United States, then that does open up a can of worms. So if we were to talk about, say, Mike, a year ago, you're in your practice, and it's the technology state of today. So it's not an explosion, but the door is creeping open. What kind of conversations would you have with your colleagues? I mean, how prepared are those people that you work with to do this?
So this is a great question, and I think it has been totally ignored to this point, and that is this. When a provider orders a test, they figure the test is just going to be done right. They figure that the result they're going to get has analytical validity, clinical validity, and clinical utility. It is assumed. Except that we happen to know for things as straightforward as HER2 new testing and ERPR testing that simply is not the case. So there's a huge gap there. And unfortunately, I think we as payers, for the reasons that Karen enumerated, actually, we can't help them. And the reason we can't help them is this. Up until the first of this past year, we had the stacking of codes. So it's a little bit better because they added a bunch of codes. So at least we know what we're paying for. But there might be 75 different test providers that build that same code, and we cannot possibly validate the efficiency and the accuracy of every single test orderer. And this is especially a problem because most of those tests are laboratory-developed tests, which are not regulated by the FDA. And there is a tremendous leadership vacuum right now in terms of someone taking ownership of this problem. Now, Palmetto has tried to at least track some of these laboratory-developed tests via the Z-code mechanism to know what they're really testing, right? But that's just to map so that we know what we're paying for. It does have nothing to do with quality, and there's a big problem with that.
Jan, do employers who are trying to advocate for wellness, because we know that's the next big thing for employers, do they know any of this?
Most do not, and that's a great question. Most do not. One of the coalitions that I'm involved with became aware of this issue as we talked about what the Supreme Court decision meant. And they brought in the major players in their region. And interestingly, every single one of the payers had a different answer to this. So as they're reaching out to their experts, there is not even consistency among all the payers, which really worried them significantly. And then they said, well, who do we then go and get an answer to? The other problem with this is very interesting. One of the large employers in this coalition allowed a year ago people's flexible spending accounts to be able to be used for the consumer-oriented testing like 23andMe, and it created a disaster. When they looked at their data around the follow-up testing that was being done. And so the coalition as a whole is actually looking at making a statement that FSAs will not cover home testing. As Karen talked about talking to your families at the holiday, I'll be interested if we come together next year and we ask people to raise their hand how many of their family members decided that somebody was going to have the whole family get testing. I will tell you, my brother came to me and said, how about if we give each other this for our Christmas present this year? And after I got done having a seizure disorder, I spent a lot of years on the payer side. It was very frightening. That is going to be a lot of people's holiday gifts. So we have a whole separate, we have the medicalization and then the population of this that we don't have answers to, but we have to start to get some oversight, as you talked about, Mark.
Yeah, so apropos of the title of the conference. So what's appropriate consumerism in this space? Right? What's appropriate consumerism? Right. So 23andMe is not expensive.
No, and
So
it's easy to do.
It's easy to do. A lot of stuff isn't actionable, like whether or not you can taste radishes or whatever it is.
Right.
But
I'm at high risk for obesity, by the way.
so am I. But I haven't been tested.
Related.
There'll be a separate session later for this.
So I read an interview with the lady who's the CEO of 23andMe. Probably some of you did. I think it was in the Wall Street Journal, New York Times, can't remember. And she basically said, well, everybody should just do it. So the issue with everybody should just do it is this. Everybody should just do it, and then who should inform them about the results? Who should counsel them about how to act on it? And what are the downstream effects of that? And we are actually trying very hard to try to get our handle about how people utilize results to make decisions, but we don't know very well. I mean, I could pose you at least 10 hypotheses about factors that influence what decisions people make, but we don't know. For example, do minority populations handle that information differently? We know they're probably not tested enough,
Right.
but do they handle it differently?
Well, your
What is
health
the role?
beliefs come into play.
Education, a whole lot of stuff.
Absolutely.
Yeah. So I mean, it is really uncharted water, and it's really scary water. Because I was talking to a medical director for one of these companies that's got this next gen platform, and she basically said, "Well, you know, we're going to expect every American to have this all on a little card or a zip drive, and they're going to walk in to the ER, and the doctor's going to plug it in, and it's going to inform how the doctor makes decision about care for the patient. So tell me exactly where we validated that model for care. I don't get that." So
And are we training our doctors in medical school and residency to be able to respond to that?
well, I'm sure there's an industry that's going to spring up that's going to help us interpret that, so that the doctor can get a report with added expense.
Exactly. You guys stole my final question. I was going to ask, what do you think about the fact that we don't measure how the test changes physician behavior?
Right.
We have no idea. So I think in the interest of staying on track, Brian, would you be happy if we stayed on time today? All right. All right, guys. Thank you so much.